Thank you guys so much. So I'm really pleased to start with the gynecologic session. We really have a truly phenomenal group with us, really international and national leaders from all over the country who are going to be speaking about advances in gynecologic cancer. They've done amazing things to shake things up and improve outcomes for women everywhere. So our first speaker will be Dr. William Small. He's the professor and chair at Loyola University and a leader within NRG, and he'll be speaking on endometrial cancer. Dr. Akila Wishwanathan, she's a professor and executive vice chair at Johns Hopkins University, and really a huge leader in advancing MRI-based brachytherapy. We also have Allison Quick. She's assistant professor at The Ohio State University, who will be speaking on vulvar cancer. And Dr. Arno Munt, he'll be moderating the debate for SBRT versus brachytherapy. He's the professor and chair at UCSD and also a national and international leader in gynecologic cancer. So if our speakers could come up, we can go ahead and get started.
Well, I guess I'm going first. Thank you very much. And in the tradition of most good study or most good meetings, you save the best for last, and I'm first. So I'm not sure what that means, but I'm going to try to take on adjuvant therapy for endometrial cancer, radiation, chemotherapy, both or neither. And I think all I can say is yes for that, and we're done. I have a couple disclosures. They're not pertinent to this talk. So what I want to do is I want to try to quickly review the data on endometrial cancer, discuss results of some recent major trials. GOG 249, PORTEC 3, and GOG 258 are major trials that have been recently presented, and discuss some current treatments of stage 3 endometrial cancer. I want to remind people that, how do I go back? Sorry. That despite endometrial cancer not getting as much publicity as some other cancers, it is the fourth leading incident cancer in women, and there is nearly 11,000 deaths. So despite it being mostly a curable disease, it's still a very big public health issue and just getting bigger as people in the U.S. get bigger, because obviously obesity is linked to endometrial cancer. There's 61,000 endometrial cancer in the U.S. in 2017 with almost 11,000 deaths. So it still is a public health issue. And I think I stole this from AJ once, because AJ had this in his slides. And from a radiation standpoint, I like this talk. And the reports of my death have been greatly exaggerated. This is from Mark Twain. And this quote is one of my favorite quotes. There are three kinds of lies: lies, damn lies, and statistics. So you can make anything say anything you want, so I'm going to make it say the things I want to say. So I can make anything say anything. Again, postoperative RT rationale for endometrial cancer. Again, this talk is fairly limited, so I won't go into great detail regarding all of this stuff, but the most commonly cited pathological factors for radiation is myometrial invasion, tumor grade, cervical involvement, age, and vascular invasion. That is an uterine confined disease. And the importance was really demonstrated in GOG 33. And GOG 33 was kind of an observational trial, and if you looked at positive pelvic and positive periodic lymph nodes, if you took grade and depth of invasion, if you have a grade 3 lesion with deep invasion, there's a pretty high incidence of pelvic lymph nodes. And I think we've got to keep this data in mind with the growing trend of not doing lymph node dissections when you're deciding how to treat patients. And not to forget that there's a fairly high incidence of positive periodic nodes too, so you have to make those decisions on where your targets are if you're treating for high-risk disease. And this is something I also use. This is from my old institution in looking at prevalence of lymph nodes with tumor size and depth of myometrial invasion. So another thing to think about when you're talking about treatment, if it's a disease that's a fairly large disease or involving the entire endometrium, sometimes I think differently about it. So observation, radiation, both or neither? That's kind of the question. And the answer is yes. I could go back to this slide. This is from 1965, and I often give the slide noting that I'm probably one of the few people in the room that was born before this was done. But this was 41 patients. I just bring it up because it was 14% vaginal recurrence rates, 14% with grade 3 and 15% with deep invasion. I'm not sure we've progressed all that much from 1965. We knew this a long time ago about who recurs and where they recur. But there have been multiple prospective randomized trials conducted to evaluate postoperative radiation early stage disease. I won't go into all these in detail because of time constraints, but there's a Norwegian trial, PORTEC-1, GOG-99, the ASTEC-EN5, PORTEC-2, the SORBI trial, and the GOG-249. So never have we done so many trials, but yet don't really have an answer, which I think is kind of interesting. But I'll give you the answer that I think is right. So the Norwegian trial is still worth talking about because I think it was a good trial. It was published in 1980, so it's been out for a while. And it was clinical stage 1 patients treated with hysterectomy, bilateral salpingo-oophorectomy without lymph node sampling. And it was a randomization between pelvic RT or vaginal cuff RT. Everyone got vaginal cuff RT, and then half the group got pelvic RT. And if you notice, a pelvic RT is kind of different than we probably treat now. It was 40 gray with a midline shield after 20 gray. So not necessarily the most comprehensive radiation. Despite that, if you look at the conclusions of the trial, they concluded that everyone who's grade 3 deep invasion should get pelvic RT. They concluded all patients with lymphovascular phase invasion should get pelvic RT, and everybody else should get vaginal brachytherapy. I don't think we've progressed all that much since 1980, but we've done a lot of trials about it. This is probably one of the landmark trials. This is PORTEC-1, which comes from the Netherlands, and it's postoperative radiation therapy in endometrial cancer. Karen Kreutzberg and their group and Ben and everybody have done a great job with the PORTEC trials. It's been just a wonderful accruing and giving us great information. So PORTEC-1 took selected clinical stage 1 patients, grade 1 with half or more invasion, grade 2 with any myometrial invasion, or grade 3 with less than a half myometrial invasion. 700 patients, again, hysterectomy without lymph node sampling, pelvic radiation versus nothing. And they had, and this comes into play when we talk about GOG-249, they had a definition of what their higher intermediate risk group was, and that was age greater than 60, grade 3 disease, invasion greater than 50%. 2 of those 3 factors was considered high intermediate risk. And remember, grade 3 with deep invasion was not in the trial because the thought was they should get pelvic radiation. And again, this is a simple theme, and again, I'm going through these trials very quickly, but at 15 years outcome with a median follow-up of 13.3 years, the local regional recurrence was 5% in the radiotherapy arm and 15% in the no additional therapy arm. Truly a positive trial, a 10% reduction in recurrence rates. And these numbers are fairly consistent over these trials. And again, 74% of the local regional recurrences were isolated vaginal recurrences. And again, if you look at this in GOG-99, these are really consistent themes when it comes to early stage endometrial cancer. Speaking of which, GOG-99 was a trial that was running around the same time, and it was stage 1B, old stage 1B, where 1B remember that endometrial cancer staging changed from 1A, 1B, and 1C to 1B and 1C. This is old 1B. Pap serous and clear cell was excluded, about 400 patients. This was total abdominal hysterectomy with lymph node sampling. And again, the randomization was very similar to PORTEC-1, pelvic radiation versus no further therapy. And with a median follow-up of about 68-month living patients, a 24-month cumulative incidence of recurrence was 3% in the RT group, 12% in the no additional therapy group. Almost the same data as PORTEC, with the only difference being these patients got lymph node sampling. And 13 of 18 local regional recurrences were in the vaginal vault, 75%, 72%. 3/4 of these recurrences were the vaginal vault. And GOG-99 also came up with, I don't know if there's any statisticians in the room, but nobody likes this, an ad hoc retrospective review, but they also came up with their high intermediate risk group, which included advanced age, which doesn't seem that advanced as I get older, high grade, which is grade 2 or 3, outer 33% myometrial invasion, LVS size. So HIR, high intermediate risk group, was considered 70 with any other risk factors. So you can have a grade 2 minimally invasive disease in a 71-year-old, and that was considered high intermediate risk. At least 50 with 2, and any age with 3. And what's interesting about it, this doesn't get a lot of publicity, but I think it factors into what happened with GOG-249. If you look at the curves in the paper, For recurrence rates in the high intermediate risk group, there was a 14% difference with the addition of radiation, from 27% at 5 years to 13%. If this were a drug, that would be an indication trial. That's a major difference. It just gets ignored, and I'm not sure why it gets ignored. And if you look at survival, again, if this were a drug, it'd be a major indication. 88% with radiation, 74% without radiation. These are patients that got lymph node dissection. So this is pretty prominent data and speaks to maybe why do we stop treating these patients when the data shows this. And then I like Michael Bertman. He's a friend of mine, but he's not in this room, I hope. He had an accompanying editorial for GOG 99 saying, yet vaginal recurrence usually are treated successfully with radiotherapy in patients not previously treated with adjuvant radiation. So the argument was, okay, yeah, you reduce recurrences, but you can get rid of it if it comes. But if you look at actually the paper, 12 of the 13 patients in the no additional therapy arm were treated with salvage radiotherapy, and 5 of the 13 died of endometrial cancer. I'm not a statistician, but that doesn't seem easily salvageable when half the patients who recur die. Just my own observation. And this is kind of some of the data that I looked at and put together and look at 5-year survival for locally recurrent endometrial cancer. And my take home is that it's probably about 50% if you look at all the data combined. So it's certainly not easily salvageable. You can certainly salvage patients, but it's not something that's easy to do. And you can't forget that its toxicity shouldn't be ignored. Those of us that treat recurrent endometrial cancer, you typically give external beam radiation, maybe concurrent chemotherapy. There is a trial looking at that. And then you do some form of an aggressive implant or some form of therapy or surgery. So it's not an easy thing to treat. So I think preventing these recurrences is not only might improve survival, but certainly it's much less morbid than trying to treat them when they come back. Which led to PORTEC-2, which was done from 2002 to 2006. And this is stage 1 or 2A endometrial cancer, age greater than 60 in 1C, the old 1C, greater than 1/2 invasion, grade 1 or 2, or 1B, again, the old 1B, which is less than 1/2 myometrial invasion, grade 3. Stage 2A, except for grade 3 deeply invasive, which again was getting radiation. And the surgery was no lymph node sampling. And the randomization was fairly straightforward, pelvic radiotherapy versus vaginal brachytherapy. Again, building on PORTEC-1, building on GOG 99, that 3/4 of recurrences were in the vaginal cuff. The primary outcome of this was, can vaginal radiation alone reduce a vaginal recurrence rate? It wasn't they were equivalent. That was the outcome. And again, the randomization was fairly straightforward, 46 and 23 fractions like PORTEC-1 versus vaginal brachytherapy, pretty typical, 21 gray and 3 fractions prescribed to a 1/2 centimeter or a low dose rate of 30 gray. And I know this is a busy slide, and I'm sorry about that, but if you look at the events, when you look at the top, the vaginal recurrence rates were essentially the same, so it met the primary endpoint, that is vaginal brachytherapy reduces vaginal recurrence rates the same as pelvic radiation, 1.8 versus 1.6%. If you look at pelvic recurrence rates, that was a highly statistically significant increase with vaginal brachytherapy alone, although you can argue about the clinical ramifications of it. It was about 4% versus about 0.5%. And the authors conclude, which I think is a very, very reasonable conclusion, is despite the slightly but significantly increased pelvic failure rate in the vaginal brachytherapy arm, distant metastases, relapse-free survival, and overall survival were similar. So vaginal brachy should be the treatment of choice for high intermediate risk endometrial cancer. I think that's true. I think that it gets a little bit more complicated because there's so many risk factors. This paper was published and presented at the plenary session ACRO this year, and the publication is being submitted soon. And this is a phase 3 trial, pelvic radiotherapy versus vaginal cuff brachy, followed by paclitaxel and carbo chemo in patients with high-risk early-stage endometrial cancer. It was a GOG study. And one of the things, I know there's some people in the room here that were part of this designing that kind of got me crazy, to be honest with you. What it was stage 1 high intermediate risk, remember from GOG 99, those were the patients that had about a 15% improvement by giving radiation. Age 18 or greater with 3 uterine risk factors, 50 or greater with 2, or 70 with 1. Again, building on GOG 99. All stage 2 patients were eligible. Stage 1 to 2 serous or clear cell lymph node dissection was not required, was performed in most patients at this time at 90%. But what drives me crazy is they decided to switch the definition of how much invasion there's from outer third to outer half. And that was really done to be honest, because they didn't think people can calculate outer third. And I think that was a mistake, because I think that the outer few millimeters of the endometrium have a lot more lymphatics. I think it's more risk. So it's a different patient population than GOG-99, and that still bothers me a little bit. And it was determined if chemotherapy with vag brachytherapy reduces the risk of death, improves recurrence-free survival compared to pelvic radiation. And about 600 patients were enrolled, pretty evenly split. The median dose of pelvic RT was 45 gray. And this was the first study that used our Atlas. AJ and I did about 25 years ago, was it, or something like that? 25 years ago. That allowed IMRT, although still the majority of patients got 3D in this trial, 64%. Brachy was added in about a third of patients with stage 2 or clear cell serous histology, and 91% of the patients completed prescribed therapy. The brachytherapy, all sorts of different ways of treating. I won't go into that detail. And the chemotherapy, you can see, is paclitaxel carbo repeated 21 days for 3 cycles, and 90% completed the prescribed treatment in that arm. Follow-up was every 3 months for 2 years, 6 months, and annually for 10 years. And I think that this is important, because I do think that we sometimes have to think when we see patients. And I look at more imaging than we wrote as the NCCN guidelines. And in this trial, there was CT or MRI 4 weeks after therapy, every 6 months for 2 years, and annually for 3 years, which I think is important, because if you're going to determine recurrence, you have to have a consistent method of imaging. Toxicity was NCI grade 2, and the median follow-up at the presentation ASHO was 53 months. It was not designed to test equivalence, just whether chemo was better than pelvic RT. And there was 2 interim analyses. Pretty well even people in the trial, 75% were stage 1, 25% stage 2. Grade 1, 2, and 3 were evenly split between the 2 arms, and about 15% was serous and about 5% were clear cell, average age about 63. Pretty typical patient population. Acute toxicity was much more common and more severe with the chemotherapy arm. Grade 3 or higher adverse effects were 11% with pelvic radiation versus 64% with the chemotherapy arm, and that's not surprising. And there was 1 grade 5 adverse event, which was really related to disease progression. If you look at late toxicity, they were pretty even. Grade 3 or higher were about 12% in each group. There were, again, 2 grade 5 adverse events, and again, disease progression not thought to be related to the treatment in 1 patient with renal failure. It's interesting, and now this is not a, Time C has also come out, which is IMRT versus pelvic RT for postoperative, which was highly statistically significant. I only mention this, the standard and IMRT seem to be the same, but that was not the end point of this trial, and I don't think the data was collected in enough of a way to say that IMRT is the same as standard 3D conformal. But I'm not a statistician, but if you look at relapse-free survival, that looks about the same. If you look at overall survival, that looks about the same. The 36-month relapse-free survival was 82%. It was about 90% for overall survival. Pelvic and periodic nodal failure is more common in the brachytherapy arm, which is not surprising. There was no significant treatment heterogeneity between arms with respect to relapse-free survival and overall survival, including the variables studied, which is stage, histology, performance status, and lymph node dissection. This is the cumulative incidence of pelvic and periodic recurrences, which again was significantly reduced by pelvic radiation. And this is a large randomized phase 3, did not demonstrate superiority to chemo and brachy in a cohort of high-risk early-stage endometrial cancer. Relapse-free and overall survival was not improved in all subgroups, and analysis of failure pattern showed a significantly lower nodal failure rate in the pelvic RT arm, despite 90% of patients getting lymph node dissection. And acute toxicity was significantly higher in the chemotherapy arm, so the conclusion, which much of the chagrin of some of my gyne colleagues, is that pelvic radiotherapy remains an appropriate and probably preferable treatment for high-risk early-stage endometrial cancer, and better treatment strategies still need to be addressed for systemic disease, because the chemo didn't seem to make that big a difference. So I think that if you ask what the standard therapy is, at least in the US, it should be pelvic radiation. This is an article we wrote a couple years ago, and we talked about the role of vaginal cuff breaking. I'm just going to touch on this. And I think that this gets really confusing. So when I talk to patients, I use this kind of thought process, and this is, I don't have enough time to go over this in detail, but I think you have to kind of go over what the the diseases, the mild mitral invasion, the grade, the adverse effects, meaning age, LVSI, and/or large tumors, and try to come up with a risk of recurrence and try to come up with how much reduction in risk of recurrence there is with the addition of radiation. And again, for the sake of time, I didn't put this slide in, but there is some good data on patient preference. Patients sometimes will take vaginal brachytherapy for a very small improvement in outcome. So what I stress to our gynocs or referring docs, send them to us and we'll talk to them. Don't talk to them yourself, because there's a very minimal morbidity vaginal brachytherapy, and some patients will take treatment for a 3 or 4% improvement, but that's a discussion we should have with the patients, not the gynecs. Hopefully there's no gynecs in the room. So later stage disease, I'm trying to go through this quickly. These are the 2 trials that were presented at ASCO last year that I don't think yet are out in a manuscript form, but they are very good studies. And again, PORTEC, again, does a great job when doing these trials. This is PORTEC 3, which is high-risk endometrial cancer, chemo-RT followed by chemotherapy at 4 cycles or RT alone. The inclusion criteria was stage 1, grade 3 with deep invasion or lymphovascular space invasion, stage 2 or 3, or stage 1 to 3 serous or clear cell cancers. Pretty evenly distributed regarding the tumor characteristics. About 40% were grade 1 or 2, so they're relatively lower risk in the grade. 30% were grade 3, and about 30% were serous or clear cell, and about 45% were stage 3. And I'm going to go through this pretty quickly. Type of surgery, obviously, for stage 3, you had to have some kind of lymph node dissection, so it was about 60% with lymph node dissection. And these are the outcomes. Survival, overall survival, and failure-free survival at 5 years was 82% in the chemo-RT group versus 77% in the RT group, and failure-free survival 76 versus 69. Distant recurrences, as expected in the chemotherapy arm, were reduced, but only by about 6%. Failure-free survival on multivariate analysis was statistically significant for combined therapy. And I'm just going to kind of the take-home message. The take-home message is for patients with stage 3 endometrial cancer, they had a lower 5-year failure-free survival and overall survival compared to grade 1 or 2, which you would expect, 79% versus 64% for failure-free, and 83 versus 74. But it did have the greatest benefit for combined therapy. 69% for the chemo-RT group versus 58% for RT, a 10% difference. And the 5-year survival was about 10% improved with the addition to chemotherapy to radiation. So the conclusions, at least at this relatively early analysis, which I would agree was there's a trend overall in the patients for improved 5-year failure-free survival of 7% and 5% overall survival. But there was a significant benefit in the stage 3 patients, and there was more toxicity. The other trial that was presented at ASCO right afterwards was GOG 258, and I'm going to kind of go through quickly just in the sake of time. These are patients that all had pelvic lymph node dissection. It was a randomization between chemo-RT followed by chemo versus chemotherapy alone. Relatively well distributed. Most of the patients were stage 3C. The treatment delivery and discontinuation was when you went to the chemo-RT group, only 310 got 4 cycles of carboplatin, 374 in the chemotherapy arm. So there was more chemo given in the patients that were randomized to chemo-RT. This was an RT and chemo versus chemo alone trial. This is a cumulative incidence of recurrences, vaginal recurrences at 6 years, were 7% in the chemo and 3% in the chemo-RT. And the pelvic or periodic recurrence at 5 years was 20 versus 10. Think about PORTEC 3. These are pretty high recurrence rates, even in the patients that got chemo-RT. This was a cumulative incidence of distant recurrences. Again, remember the PORTEC trial, about 6% improvement in distant recurrences. They're very similar, 27% versus 21%. Overall survival, again, was very similar, 70% in the chemo-RTs and 73% in the chemotherapy arm. And my interpretation of this data is just kind of a take-home message, is that there was reduced chemotherapy delivered in the chemotherapy combined treatment arm, and there was a delay in chemotherapy. And we've developed a phase 1 trial to kind of bring the chemo earlier. Albeit a different population, the chemo-RT arm of PORTEC 3, the pelvic vaginal recurrence rate was just over 1% versus 13% in GOG 258. So I think we really need to have the exact patterns of recurrence, and the high-risk recurrence in 258 will need to be described. Chemo-RT, though, reduces the risk of low regional recurrence, but did not have any obvious effect on overall survival. And I think the exact role of radiation, specifics of delivery will need to be determined. I have not stopped treating stage 3 disease based on this data, and I think a lot of us that treat advanced endometrial have not. There are occasional times when I won't give radiation, but I don't think this has changed my way of treating. So my conclusions for advanced stage diseases, for stage 3 endometrial cancer, both PORTEC-3 and GOG support the use of chemotherapy. I think that is pretty clear. The role of radiation in these patients are yet to be determined, although it's certainly reasonable to give radiation at a minimum to improve local regional recurrences that we described. They're difficult to treat. And that last one is not part of this talk. All right, thank you very much. Sorry I went through that so quickly.
That was a wonderful talk. Next will be Dr. Vishwanathan.
Well, who can follow Bill Small? Sorry, we're going to have fun during the debate in a few minutes, but for right now, I'm going to talk about cervical cancer and some of the latest updates. These are just the learning objectives. We'll get to the talk. So I think we're going to start with something that we don't necessarily prescribe, but that it's important to know, that there are still patients that are getting cervical cancer despite about a decade of vaccine use. Why? Well, we're not sure. Some of it is that only about 30% of eligible women, girls in the United States are getting vaccinated. And so there are recent publications from just last month in The Lancet that talk about worldwide incidence of cervical cancer and the impact of the HPV virus. And there are many millions of women that have been saved from having cervical cancer due to vaccination, but we still have this issue. One of it is that the initial versions of the vaccine only covered HPV 16 and 18. So in 2015, a New England Journal paper was released that showed a new 9-valent vaccine was available, and that is now being implemented as part of routine in gynecology and in pediatric clinics. So we hope that with this broader valence, we'll be able to fully eradicate not only cervical cancer, but all HPV-related malignancies, including anal cancer and head and neck cancers. We also know, we historically had thought about HPV as being related to the tumor suppressor genes retinoblastoma and P53. And with now this first publication on landscape of genomic alterations, and then subsequently the TCGA, which is the Cancer Genome Atlas, that there are more than 25 genetic alterations. Although there's some crucial driver mutations that occur, there are many, many other mutations that are part of the panoply of genes that are impacting outcome and that are affected in cervical cancer. So P53 mutations account for only about 25%. We, when looking at subtypes, also know that the different subtypes respond differently. A lot of this data was publicized with the head and neck literature. Part of the reason is that in cervical cancer, although we know that subtype's important, the vast majority of women are HPV positive, and over 80% have HPV 16. Now, if you look at the curve at the bottom on the left, it's the difference between chemo-RT and RT alone in the HPV 16 population. And what we learned from this paper, although it needs to be validated in a larger series and internationally, is that the reason why radiation worked for 100 years in cervical cancer is that the vast majority of women were HPV 16 positive, and that the true benefit for chemo-RT is likely subtype specific, with the higher risk HPV 18, which has a higher risk of metastasis and distant metastases, having a much greater response, as it is a higher risk subtype. We also know that we've historically debated the difference between adenocarcinoma and squamous cell carcinoma with the presumption that adenocarcinomas fare worse. We know this in the postoperative population from the old Landoni trial, that the patients with adenocarcinoma had a higher risk of recurrence and relapse, and people often wonder if the true SEDLIS criteria that were published for intermediate risk patients in the post-op setting, if that actually truly applies to adenocarcinoma, or is adenocarcinoma so bad that every adenocarcinoma patient should get RT or even chemo-RT. These are unknown questions at this point. So the GOG had run prospective trials looking at chemo-RT, and in this particular paper, they combined the data and looked at the difference between adenocarcinoma and squamous in the locally advanced setting, and found actually there were 11% of patients that had adenocarcinoma histology, and that if you gave chemo-RT, that difference in survival that's seen in RT-only patients goes away, so that chemo-RT makes the difference between squamous cell and adenocarcinoma go away in terms of survival. So that again, is something that's very interesting, and I think whether we should be giving chemo-RT for all, even in the post-op setting, is unknown based on this data. This then resulted in those combined 5 prospective trials were then put together for creating nomograms. I'm still hoping somebody creates an app where this makes this easy, but otherwise you just have to go to the paper and sum the scores up and take a look at where your patients fall in terms of risk profile. I put the 2 little blue boxes around stage just because it's interesting to note that the most significant prognostic factor in cervical cancer is always stage, but stage is a surrogate for size. And when you see an overlap between stage 1B and 2A in these nomograms, it's really reflective of the fact that even though the stage is higher, if a patient with stage 1B2 has a very large tumor, their prognosis is actually the same. So stage 2A and stage 1B2, the prognosis does overlap in these nomograms. Now, something that has been debated for many years is whether or not to do IMRT in cervical cancer. IMRT is, I think, becoming a lot less controversial as we start implementing IMRT in constructive and thoughtful ways. The most common way that it's used is in treating the periaortic nodes, because you can adequately spare the small bowel and carefully carve the duodenum out so that you don't cause duodenal toxicities, which can result in fatal perforations. What we've learned over the years in publications that demonstrate fatal duodenal perforations is that you must use small bowel dose constraints. And so the small bowel dose constraint I use is 5 cc less than 55 gray in planning, with a maximum dose of 15 cc's to 55 gray. Another dose constraint that's used more in the pancreatic literature is 30 cc's less than 55 gray, and some people use a 2 cc up to 65 gray. So a dose limit that's higher if you're contouring and treating a periaortic node that is adjacent or high up adjacent to the duodenum. What do you do when you're treating the pelvis with IMRT? Well, you know, some people had done a match line and separated and done either APPA or 4-field, but that's very complicated because the match can become either cold or hot in an area that you want to treat. So it's much simpler to do IMRT to the whole field. The most important thing is to realize I have seen and reviewed plans where people contour the cervix and the uterus and just give 7mm margins around that. And that is absolutely inadequate because the uterosacral ligaments, we're treating, you know, locally advanced cases. We're not treating the simple stage 1A ones where the surgeon would just take out the uterus. Remember, they would also take out all of the perimetrial ligaments and the uterosacral ligaments in a radical hysterectomy. So all of those ligamental tissues are at risk and for harboring disease. And if we treat with too tight margins, we're going to miss not only the uterosacral ligaments that cross around the rectum, but we may also miss tumor if we don't take into account bladder filling, which is very hard to standardize. So I always say you can treat with IMRT, but don't try to spare the rectum to 45 gray, and don't really try to spare the bladder too much because the tumor can fall right into that space. And you know, the goal really is sparing the small bowel, not so much the bladder and the rectum in cervical cancer. Remember, we're only going to 45 gray. We're not going to nearly as high doses as you would to the entire prostate. And prostate radiation, where sparing the bladder and rectum have become major issues. But again, the prostate is encapsulated. It doesn't spread to parametrial or uterosacral ligaments. So I think we have to learn the specifics of doing IMRT safely in cervical cancer. We do know that identifying the PET-positive nodes is now feasible. They tend to cluster, particularly on the left side because of the drainage, and that we can get outstanding overall survival results and very, very good nodal control with dose escalation. Whether your preference is to do a small SIB or sequential is fine. Publications and the Anderson technique is to do the SIB with 2 gray per fraction to the node and 1.8 gray to the surrounding tissue. So you end up with 45 and 50 gray, and then to follow that with a sequential boost, anywhere from 60 to 65 gray total, depending on tolerances, obviously, of your small bowel. So I'm going to shift now to talking about MRI utilization in external beam first, and in treatment planning, and then in brachytherapy. So MRI is extremely helpful at identifying the tumor. Once you start doing MRI routinely, you never want to look back. It gives you some information up front about where the disease lies, and it obviously helps make sure that you cover all sites of disease. This is especially crucial if you are starting to do IMRT for your contouring. But you'll notice when doing MRI that there is very rapid regression of the tumor during the course of treatment. And so the big question is always, how often do you replan? Well, if you give wide enough margins again, then you don't have to replan. I moved to Hopkins just a few years ago, and they do cone beam CTs daily because the head of physics there invented the cone beam. And it is one of the things that I realized you just cannot see the tissue separation between the rectum, the uterus, the cervix, and the bladder well enough, I think, to know exactly and be confident where these tissues are located. But an MRI gives you very, very robust information. And we have an MRI simulator and can look at how these tissues are changing. But without that, I think it's very high risk to give, again, tight margins and try to replan, or not replan, but just rely on a daily cone beam, because you do sometimes lose the nuance of where the actual uterus and cervix are sitting. And it's very, very hard, even if you ask a patient to fully empty or fully fill their bladder, for them to do that consistently and reliably every single day. So I think we know that these tumors are ones that you can go from 5 centimeters down to nothing within 5 weeks. And that change is really important and somewhat different than what we see in other areas of the body. So we also know that MRI is significantly better than clinical exam from data that came out now almost 2 decades ago. But it's a pretty good surrogate. So, you know, if you don't have an MRI sim, you're not doing repeat MRIs in your clinic, just being able to, during your assessments, your weekly assessments, see the tumor and have concern if it's not shrinking is important. We do know that the rate of shrinkage is related to outcomes. So if the tumor shrunk less than 20% over the course of the 5 weeks of treatment, there's a significantly lower local control and disease-specific survival rates, as shown here. But these were not compared on multivariate analysis. So we do need, again, repetition and another series of this type in order to confirm this and put this in the context of disease stage and other prognostic factors. We did run a session through at that time, the RTOG, looking at what were the appropriate contours, and these are just inter-observer. We had many physicians contour and show us what were the correct volumes, but I'm just going to show you the consensus volume. And you can see here the main point is that the parametrial areas are so large that they fill up the entire width of the central pelvis. So there's really no way you can spare, and you don't want to spare, anything between the cervix and the nodal volumes. You should cover everything from sidewall to sidewall. The other thing to notice is that in this particular picture, there's a very full rectum with gas. And what we know from other studies is that gas volume can change dramatically even while a patient's on the table. And so the rectal filling can push the cervix. If the patient's supine, and if they have air in their gas at the time of simulation, if they're on treatment and now they have diarrhea or bowel changes, the rectum's now empty, the cervix can fall posteriorly. And if you've spared the rectum, you're now sparing the posterior portion of the tumor. And the patient will end up with sigmoid relapse and fistula due to recurrence. So you have to be extremely careful, and really the goal is not sparing the rectum again for that reason, organ motion and just the uterosacral ligaments that go so far posteriorly. You can also see that the vagina is an important structure that needs to be contoured, and the level is just to the bottom of the pubic symphysis to make sure that you are covering adequately the full length of the vagina, or at least it's 4 centimeters below the area of gross, the closest area of gross disease. So what else does MRI tell us? Well, you can get lots of multiparametric information. Here you see these are different ways that we can look by contrast and by using DWI, and these are now being tested in terms of their prognostic value. But we do know that, again, this rapid regression, this is now at the end of treatment, can show us different features on these different types of MRI scans. And what to do with this information in terms of our brachytherapy boost is where we're all interested in looking. So again, lots of movement. The tumor, as it shrinks, can result in the tumor shifting from an anteverted to a retroverted position. Again, as the tumor shrinks and bladder filling changes, you can get drastic shifts up to 3 to 4 centimeters of the uterus and up to 0.5 to 1.8 centimeters of the cervix. I'm just going to flip through this. This is the cone beam CT data that shows in 10 patients that the rectal volume and the bladder volume were associated most predominantly with the shifts. And also there was one publication looking at the impact of shifts on dose, and they calculated out that in the essentially these central vectors, that if you gave tight 1 to 1.5 centimeter PTV margins, your tumor would be 50% underdosed, and about half of your treatments would miss your target, your CTV, because of so much movement. So 1 to 1.5 centimeter PTV margins were considered too tight, and obviously the largest discrepancy was with a large bladder change. So the most important is doing wide margins, up to 2 to 3 centimeters. So why do we still talk about brachytherapy? We are obviously dealing with a situation where brachytherapy has been used, and we'll talk about this a little bit more, I think, in the debate. But this was the very first US-based publication in JAMA, which had 199 cases cured with radium, and 57 of those got radium alone, and that was up to including stage 2B. So it was Howard Kelly. What we also know is that we've all seen more and more use of IMRT, and the brachyutilization rate for cervical cancer is decreased. This is showing the same data for prostate cancer. This is directly from Medicare. You can see that the rate of brachytherapy in prostate cancers drastically declined as the use of IMRT increased. And so there was a trade-off. What did that trade-off result in? A significant 25% reduction in the use of brachytherapy over a decade that resulted in a 13% reduction in overall survival. We don't like to talk about that or see that because we expect that technology is going to benefit us. And although if you look at the NCDB, you see the same thing, you realize that only 52 of those cases were SBRT. So, there are about 13,000 patients analyzed and only 52 had SBRT. So I think we have just an incredible paucity of data because SBRT is completely untested at this point. But what we also know happened, why were people using less brachytherapy? Well, it's now shifted to more HDR, which is much more time intensive. We do 5 outpatient fractions. And the need for physician time is significantly increased. The other really important thing is that if you're giving these big fractions, you need to contour out the normal tissues, whereas in LDR, you looked at ICRU points. So we do know that you can significantly reduce toxicities by doing 3D imaging, but you have to have either a CT, use your CT sim, or an MRI that you've obtained in the hospital in order to safely use HDR. I did want to bring to your attention that ICRU 89 was published last July. That is the new set of standards that all our physicists use for brachytherapy treatments. So this replaces ICRU 38, which had been used for something like 5 decades. It now replaces the point A with the MR-based GTV and the high-risk CTV for contouring the cervix, and describes how to migrate from point A to volume-based planning for cervical cancer. We do know that people are starting to use MR more in the United States. This was from 2014 and shows that we now have 38% of physicians in the United States are using MR for all cervical cancer brachytherapy, and shifting from using point A to using the high-risk CTV, so the contoured volume of the cervix, which is crucial for treating. We know that people are also using more CT, but still things like the tumor size matters, and that we see even with CT that as each treatment goes on and the tumor shrinks, if you were still prescribing to point A, you would potentially overdose the normal tissues by between 3 to 4%, because you're not taking into account the shrinkage of the tumor from fraction to fraction. If you're just prescribing to point A, you're not accounting for that variability in tumor size. And what we learned from the French, where they did this very large comparative registry type study, was that there was about a 20% reduction in toxicity from 22 to 2%. There are now lots of data that's been published with CT showing significant improvements in disease-free survival. And what I'm just going to kind of fly through here are just the comparisons of CT and MR show us that the greatest advantage to using MR is in patients that have large parametrial extension, usually the stage 2B or 3B patients. Patients that have small tumors or stage 1B2, the CT and MR completely overlap. This is data from MD Anderson comparing CT and MR, and they interestingly showed that the greatest difference between CT and MR contouring in the cervix was in patients with the highest BMI, as well as the large tumor size that we'd seen earlier. So I think that's just ability to visualize the cervix in the context of a CT. I'd started using MR back in 2004 and did a prospective feasibility type study with 25 patients, and we saw no local recurrences. There were 2 patients with persistent disease, but it was a good sign that that there was very, very good outcomes when one used MRI. We then compared MR to CT and found that basically there was an advantage in terms of overall survival for MR, but that the greatest factor was actually squamous cell histology and tumor size. But this is using interstitial and in the most advanced cases, the stage 2 and 3Bs that are large. What are some of the indications for interstitial? Patients that have vaginal involvement, very large sidewall involvement or bladder involvement, any vulvar cancer with vaginal extension that they have residual disease. We use interstitial for urethral or some bladder cancers in the GYN setting. Patients that have postoperative recurrences at the vaginal cuff, and patients, again, that have just fistula or a very, very large mass. I'm not going to cover that. And this is just data from the EMBRACE, which is a very large European conglomerate of many countries where they're looking at cervical cancer and how it's treated. It's a registry study. It is not a clinical trial. They also published data from what's called the retro embrace, where the institutions could submit cases that were done with either CT or MR. It's not an MR-specific study. And what they found was that there were 5 categories of parametrial regression that they identified, and that these 5 categories corresponded with how they needed to contour and whether or not needles needed to be added. So in patients in the what are called group 5, which are there's very little regression of the parametrial disease during treatment, they found a significant advantage for adding interstitial needles through the applicators. So nowadays we have these modern applicators that are rings or ovoids that add needles in. And they recently published last year, this is data from Carrie Tunderup, that the dose was directly correlated with local control, and that overall treatment time, which we've always known is important, you must finish all treatment in 56 days, that you can compensate after 7 weeks by increasing the dose by 5 gray. So if you have to have a treatment protraction more than 7 weeks, you can increase the dose by 5 gray for each week that you're kind of behind 7 weeks. What does that mean? You're obviously going to run into issues with your normal tissue tolerances. So obviously delay is not what we recommend, but it can be compensated for by increasing dose to the tumor. The other thing they identified is that by increasing tumor size by 10 cc's, you need an additional 5 gray for equivalent local control. So what are the dose tolerances? We have the D2cc for the rectum is 70 to 75, sigmoid is the same, and bladder 90 to 100. One can easily transition. I think this is something that many institutions are now doing. It takes a very well-trained team and takes time. So you have to work with your entire infrastructure to get the support, obviously the funding for all the equipment, but it is feasible and can be done in about 6 to 8 months when you get everyone on board. We're just using a new tracker that allows us to locate the tumor and use interstitial very safely and bring the catheter and make these actually potentially outpatient treatments, because you can just put a needle in right where the tumor is and then take it out. So in conclusion, we standardized treatment, and we are doing image-guided brachytherapy now more often, and I want to thank you for all your attention.
Thank you, Dr. Wishwanath. Then we'll have Dr. Quick come up.
Okay, this is just a brief talk on vulvar cancer, and we have just a few minutes to discuss inguinal node delineation. I chose this topic because of the importance of inguinal node status on patient outcome, and because inguinal nodal failures are rarely salvageable. So just as a brief review, we'll discuss GOG 88, which highlights some of the potential problems with groin radiation. So this is a study of patients with stage 1 to 3 clinically node-negative vulvar cancer who were treated with radical vulvectomy and randomized either to bilateral groin radiation or bilateral inguinal lymph node dissection. The patients in the lymph node dissection arm did receive radiation to the ipsilateral inguinal nodes and pelvic and hemipelvis if their nodes were pathologically positive. The dose was 50 gray and 2 gray fractions and was calculated to 3 centimeter depth below the skin surface and was treated with a mix of photons and electrons. And the treatment fields are illustrated on the right. The results of the study demonstrated that there were higher groin recurrences in the radiation arm. So 5 out of 27 patients had an inguinal recurrence. All of these recurrences were in the radiation field. And on review of their treatment details, there were no protocol violations identified. Unfortunately, all these patients died of their disease. However, in the inguinal node dissection arm, there were no inguinal failures. There are several criticisms of the radiation delivery on this trial. Most importantly, these patients were not CT-based planned, and so the depth and location of their inguinal nodes was not clear. And it's likely that there was inadequate dose either because 50 gray was insufficient to sterilize potential macrometastatic disease, or because the nodes were deeper than 3 centimeters and were underdosed. The image on the left is from a study that used a series of CT simulation scans from women treated for gynecologic cancers to estimate a depth of the inguinal nodal volumes for appropriate treatment. And they found that on average, the nodes actually were about 6 centimeters deep in the patient, and that this depth increased with the patient's BMI. So at this depth, the average depth of about 6 centimeters, the lymph nodes would have been significantly underdosed with the prescription at 3 centimeters. On the right is just a patient of mine that I treated, showing that a depth of about 10 centimeters would have been required for appropriate treatment. This is a table of the 5 patients on GOG 88 who had groin failures in the radiation arm, and it gives their prescribed dose at 3 centimeters, and then estimates the depth of their inguinal lymph nodes based on their BMI, and then an estimated actual dose that the patient would have received. And as you can see on the far right, that dose is significantly less than the planned dose on the study. So we know that depth is important to obtain from our CT imaging. In addition, we need to understand circumferential margins that are needed to treat the inguinal region, especially in the area of IMRT. We're able to treat this area very conformally. We want to make sure we don't have a geographical miss during our treatment planning. And so this, again, is a study of a series of patients, the image on the left. The red dots indicate locations of positive inguinal nodes in a series of patients. And you can see that most of the nodes lie anterior medial to the vessels, which illustrates that a simple expansion on the vessels, as we do for treating pelvic nodes, is likely not sufficient for adequate treatment of the inguinal nodes. And they suggest boundaries for the inguinal node volume that's bordered by the muscles that you can see on this CT scan. So what we need is really a large volume, and again, not a direct expansion off the vessels. The right is just an image of the similar volume, but in a thinner patient. So this is an illustration of the difference between contouring the vessels with a simple expansion, again, as we typically do for pelvic lymph nodes, compared to treating a larger volume, illustrated in the red line, which is more appropriate. So there are some additional contouring pearls that have been developed through contouring consensus guidelines, which is a very useful paper for contouring both the vulvar primary and the lymph nodes, as a great resource for what can be a challenging site to treat. So if you are treating a patient who has gross nodal disease, either in the preoperative or the definitive setting, the GTV for the lymph node should include any grossly involved node on your imaging. And again, the CTV should encompass this entire nodal bed, as we just discussed. This will also take into account the presence of any extracapsular extension. It is recommended that you treat the nodal echelon above the highest lymph node involved. And if one positive node is present, the contralateral groin should also be treated. And finally, this refers more to pelvic lymph node contouring. However, there may be slight differences depending on what other structures are involved from the vulvar primary. For example, if there's distal vaginal involvement, the bilateral inguinofemoral obturator, internal and external iliac lymph nodes would be addressed. However, you may consider adding in the presacral nodes if the proximal vagina or the anus is involved. And that's all.
Well, that was excellent. Thank you. We're going to move on to the debate portion. So Dr. Vishwanathan will be taking on the portion for in support of brachytherapy, and Dr. Small will be taking support of SBRT for gynecologic cancers, and Dr. Munt will be moderating.
So I was thinking back to the 1990s when I would be sitting in my office when IMRT first came out, and people would call and they would want constraints. I remember the 1990s, a lot of us there was a few publications on IMRT, and people would just ask someone, what should the bowel constraint be? What should this and that? And it was sort of until the consensus came along, we really didn't have anything. And every once in a while, someone would say, okay, when you don't do brachy, what are your constraints? And I'm like, oh, I don't think of that because I usually do brachytherapy. But it kept going on like this, and people became, well, if you didn't do it, if you wouldn't do it, what would you? And so it became this issue about IMRT versus brachytherapy, which I never thought was really an important one because you can't get the same doses, you can't do these the same that we can with brachytherapy. However, SBRT was always an intriguing issue because with lung cancer, we saw what a difference that made in control. And it really became a question about not just IMRT coned down to some dose, 76 gray or something, but it really became a question about SBRT. So we thought today we'd spend the last few minutes looking at this question about could SBRT be a reasonable tool in lieu of brachytherapy or not? So we're going to have two opinions on that subject. So I think, Akila, you're first. Which one? Oh, no, which? Yeah, let's keep Bill's for last. Let's start with Akila.
Hi, everyone. We're going to have fun. I'll take my slides. Is it? We're in a situation where we have, as you know, a lot of experience using brachytherapy, but we also, as a field, each and every one of us likes to innovate. I think people choose radiation oncology because we like, obviously, doing what we were trained to do, in residency and from our mentors, but we also like technology. And so are, as a group, I think much more inclined to start thinking about ways that we can incorporate technology, always, though, wanting to do the right thing. So the question now is, well, what's the right thing? So actually, we'll go back, yeah. I, have the good fortune of being able to debate with Dr. Bill Small, who is an esteemed colleague and one whose advice and mentorship I've had for many years, and we've been great colleagues over many years. But I have to say today, I'm likely going to disagree. We have not only 100 years of good data for brachytherapy, but we have good toxicity, and we are not only saving our patients and have good survival rates, but we also have outstanding, now with image guidance, significantly lower toxicity rates. So this one is titled SBRT. It's the second set of slides. Yes. So brachytherapy, the way of the future. We have a future to think about in brachytherapy. So we're going to debate, and my co-debater, Dr. Small, as you can see, extremely photogenic, very nice. He wears a halo often. He's always tells us the right thing and is a good thing. We also have Dr. Munt as our moderator. He not only wears a halo, he wears wings. Because he gets to adjudicate without any kind of conflict. But we're all friends, and so we're going to have fun today. So what are the major issues with SBRT? The first is that we have absolutely no safety data. We really don't know in GYN how to do this. And if everybody told me that they were doing an MRI on treatment with every fraction with MR-based imaging and gating, I'd say maybe. because having tried this, it's quite complicated. We also have no really reliable toxicity information because we don't have 20,000 patients that we can say, this is what the result is when you do this to the rectum. How do you prevent somebody from dying when you're giving a large fraction and not having a fatal perforation of their rectal wall from a large fraction? We, again, don't really know what our DVH dose constraints are. We have a much higher integral dose to surrounding normal tissues, which may cause long-term side effects, second malignancies. And again, with cone beam, it's very, very hard to locate the target and the organs at risk. Our reimbursement's always fluctuating, and that's a driver for this for, I think, a lot of the utilization. And so we also have to ask, what do we do for each and every different disease? So we have inoperable uterine cancer and cervical cancer and recurrent endometrial cancer and vaginal cancer. Are there some of these where this might be indicated, some of these where it's not because it's truly unsafe? What about all the different sizes of tumor, the different extension of disease? So I'm going to show you some cases. This is at the top. This is a locally advanced cervical cancer. Where we have very tight and conformal brachytherapy volumes. And you can see at the bottom a planned equivalent, an SBRT, and just, the spread of dose, the higher integral dose, the inability to account for true organ motion, even if you redo a cone beam CT, because of the inability to get fiducial markers that cover the entire uterine and cervical area. We always talk in pancreas about 3 fiducial markers. But if you implant them, as a surgeon would or as a physician would, they all end up in the lower part of the cervix. These organs and the disease are so large and so spread that you get quite heterogeneous movement of the different parts, if you will. So the uterus moves quite separately from the cervix when you look at a cone beam, and you'll see, unless you have calcifications in the uterus, that you're not reliably going to be able to see it. So, the fiducials are telling you about the few, centimeters around them, but they don't really tell you what's going on 8 centimeters above at the fundus of the uterus. This is a case of inoperable endometrial cancer. You can see the dose distribution at the top with the double tandem, the Roddy applicator, and how nicely conformal it is to the area in the center of the uterus. And you can see at the bottom an equivalent, again, higher integral dose, same issues with organ motion. Feasible question about how wide of margins do you give when you're doing SBRT? Well, some people in the brain might talk about, a few millimeters, but we have no idea what would be an adequate PTB margin given the amount of swelling that can occur between fractions, the amount of shifts that occur in something as highly mobile as pelvic structures. So, why is this a debate? Well, not all of us actually ever wanted to be surgeons. Some of us did, but not everyone. And so we have tricks and tools with brachytherapy applicator, but we're also now much more looking at our clocks and our time. We're always worried about what's going on with our day, and brachytherapy takes much more time. Not that brachytherapists sleep while their planning's going on, but when you do SBRT, could you be a little more efficient and do something that seems like it's part of the routine as you would do with others? So again, brachytherapy, 100 years of technology, curative modality, 50 years before the LINAC was ever created, and before chemotherapy was used. We know, and I showed you already in the lectures, the data that we can improve survival. Brachytherapy is a volume that moves with the patient. We don't have to deal with organ motion. I talked about this. And I am going to quote Dr. Small's own paper. Compared with other external beam techniques, the superiority of brachytherapy is explained by its unparalleled dose distribution, characterized by low integral dose and sharp dose gradient.
That came out last year. Things have changed.
All right. Later in the paper, the superiority is not free of its limitations. You can find it's occasionally challenging. It might be associated with non-trivial side effects, and physical constraints such as normal variations with age might exist. Some patients refuse brachytherapy insertion, some. I have to say that as a field, we need to be genuine that we're not inadvertently referring curable patients for IMRT or SBRT because we don't want to do brachytherapy. I think we have an ethical and a moral dilemma there to treat patients with brachytherapy first. So, in the absence of brachytherapy, new techniques may offer dose distribution that is not exceedingly inferior to that provided by brachytherapy. Well, why are we talking about being inferior to something we know works? So, I think I would take that as a rounding endorsement from Dr. Small of the use of brachytherapy. We'll talk about the other point, the gorilla in the room, which is that there was decreased reimbursement for brachytherapy. We would not be sitting here talking today, I think, about this issue if, one, we didn't love technology, but two, if brachytherapy billed 10 times higher than SBRT. And I think we as a field need to be genuine and honest about how we react to changes in reimbursement and why that influences our patient, and does it influence our patients in a way that is meaningful, that impacts their survival, and so we're all always doing the right thing. So we need to work with our legislatures and lobbyists in Congress to get them to reimburse treatments that impact survival. We all want to do the right thing. But we saw, as you can see here, from 2009 to 2014, drastic cuts, particularly in outpatient services for brachytherapy. This just isn't fair. It's just not right, because it means that we're all pushed to do things that we might not want. This is in prostate cancer, and you can see this in GYN malignancies. I don't want to get into the details, but the general theme is there that we need to do cost-effective, value-based treatment. Now, what about data? This is the last point. There are in total, these are all the publications with SBRT, 207 patients reported, 73 with SBRT, the rest had IMRT. Varying doses, varying normal tissue toxicities. You can pick and choose. If you want to report all stage 1A1s, you might be okay, but we have no idea. We just don't have enough data. And that's it. Thank you.
That's really not fair using my own words against me. Don't do what I say. Do what I say, not what I do, or whatever that is. So I'm gonna argue that SBRT is the best thing to do to slice bread. Brachytherapy is an old and costly form of therapy. It's really time to move on. We should not be doing these difficult. When you're in the OR and things are bleeding, it's messy. We could sit behind a computer and figure things out. Why would we ever want to go in the OR? I mean, Madame Curie really hasn't changed since 100. I would say it's, as opposed to tried and true, it's old and wasted. I mean, telephone books were great. You can open it and find something quickly, but I don't get a telephone book anymore. Slide rules were great, but there's now a computer and you could do everything on your phone. You used to have to call a telephone operator, and remember those of us that had phones that you had to spin? Why would we keep doing the same thing? It just seems very, very silly. So is brachytherapy even available? So we're talking about things where cervical cancer is happening. Why would we use a technology that you can't even use? And if you look at age-adjusted risk, 85% of cancers occur in developing countries with limited access to screening, diagnostic, or treatment capabilities, including brachytherapy equipment or expertise. So for the good of humanity, we need to start developing different ways to treat cervical cancer, because most of the cervical cancer can't get brachytherapy. And this is the paper that she quoted and Akila quoted. So we did this. That was just to throw it in so the editors would get it published. But we talked about external beam techniques to boost cervical cancer when brachytherapy is not an option, which you can argue is never an option. Theories and applications. So we kind of went through things, and I won't say that, but this is dose and fractionation in radiobiology. We can really do some interesting things now. Back when I used to do brachytherapy for cervix cancer that I don't do anymore, that's not true. We couldn't do SIB. We can do simultaneous integrated boost. We can shorten the interval treatment. And this is just, we went through some biological things in this paper about how, if you're going to do it, how you can do it with an SIB technique. If you look at this, if you do an SIB technique, you get about the same BD Gray's 10 as an implant of 6 Gray times 5. So you can make the doses appear really pretty good. And look at how cool that looks. And see, it's a precise planning where it comes out to the middle of the thing. And look at when you do brachy, you get this tail of high dose. What does that high dose do? It probably causes necrosis and fistulas. It seems horrible. Whereas with SBRT, you got a nice stop and it stops. It's really cool. You know, you can, if you think you can still do brachytherapy, I guess you can do it for people that don't have access, for people with comorbidities. But again, we should be doing SBRT for everybody. This is, I think, the same, you stole this from our article. So this is, we can look at this data differently. Dr. Viswanathan elected to look at it as the glass half empty. I think it's half full. I mean, this is a bunch of papers that show local control rates that aren't that bad. In fact, I'll take 2 of these patients. This is a patient, now 6 patients might not be a lot, but there's 6 patients treated with a Cyberdyne boost after 61.2 gray simultaneous integrated boost, gave 20 gray and 4 fraction delivered to the 8% isodose line. So we're getting that dose in homogeneity we get with brachytherapy. No grade 3 or 4 toxicity, and all the patients were controlled. Granted, it was a median follow of about 6 months, but at 6 months, every one of these 6 patients were doing great. And this is another huge trial. 11 patients, that's almost double the last trial I just talked about, who got a simultaneous integrated boost of about 60 gray and then 5 fractions of 6 gray prescribed to 60 to 70% isodose lines. And again, no recurrences or late toxicity. I mean, this is just amazing. And this, Dr. Viswanathan also alluded to this. I take this data a little differently. This just came out in the Red Journal. It was evaluation of delivery costs for external beam radiation therapy and brachytherapy for locally advanced cervical cancer using a time-driven, activity-based costing. And this is the brachytherapy workflow. This is too complicated. We don't have time to do all this stuff. We got other patients to see. And this is external beam. Look at how clean that is and how simple that is. Why would we do all that stuff with brachy? And you look at time. This is an interesting thing. So it looks at, this is a summary of personnel time and cost in this paper. If you look at the attending times for external beam and brachytherapy, you spend a long time doing brachytherapy where you can be done with SBRT quickly. And again, this is global reimbursement and you make less money. You know, not that this is to make money, but you know, we had to pay for the trip to ACRO and stuff like that. So you could actually make more money, use less time, and get great outcomes. I'm not sure why that's a bad thing. So if you look at that, it really hypothesized maybe the difference in treatment and physician effort may be why brachytherapy is going down. I would say it's just because we don't like to go to the OR. So in conclusion, I think brachytherapy is an old and dated technology that essentially hasn't changed for 100 years, often not available where it's most needed. Data suggests in those 17 patients that good outcomes in selected series with no brachytherapy. And it's economically challenging to deliver brachytherapy with current reimbursement rates. Thank you.
As far as, I don't know if this is on, the MRI planning versus CT planning, I enjoyed your talk. I find that most of my patients with cervical cancer come to me with a PET scan, which we always fuse in our planning process, and I wonder how you feel about the CT PET and how that influences just purely the CT versus MRI planning.
Yep, so I think it's great to use the PET for the initial simulation, and we use the PET all the time for nodal contouring, particularly determining if they're enlarged nodes, what kind of boost they should get. So we do either an SIB or sequential boost to those enlarged nodes that are seen on the PET. There is one paper on using the PET for the brachytherapy planning, but it's very difficult to get a PET after 5 weeks that's consistent and reliable because inflammation is something that the PET, the FDG's taken up by, and so if you just have an inflamed area after 5 weeks, which external beam causes, you get false positives. So we don't do FDG PET for brachytherapy routinely, and that's where the MRI comes in very helpful. You know, if you don't have an MRI, that's fine. Using the PET is, I think, more important for determining. If you were just going to get one study at diagnosis, I'd get a PET CT because you can use it to determine distant Mets and nodal disease. If I were going to get one image at the time of brachy, I'd get the MR because it helps you define the most precise target volume.
Yeah, just a question about the contouring with groin. I know it was Dr. Quick's talk, but perhaps you could address that. A very nice discussion of drawing the volume, not just about the vessels and expansion, but the actual volume in the groins. But then I presume, this is what I tend to do, you then add, say, 7 millimeters for a PTV. Is that correct? Because on the RTOG
Yes.
atlas, it just shows that. It doesn't talk about an expansion. So is that what you do? You expand it again, and by how much?
Okay, right, that was the CTV, so you would definitely still add a PTV, and that may be 7 millimeters, 1 centimeter, depending on patient setup and other reasons why you would, choose your PTV. If they're larger, more obese, I tend to go with a 1 centimeter margin. I don't know what you guys do, but.
No, I think that's true. I think one thing we should mention that wasn't part of Allison's talk is that also be careful with your PTV margin, the vulva, because the vulva can swell, and if you're doing IMRT, you should probably put a false structure in because things can swell. So I agree. I put about 1 centimeter PTV more on the vulva depending on what we're treating,
Yeah.
especially if it's intact.
Okay. And with the groins, do you, how much do you trim at the skin? I mean, it's a little different. Head and neck, we do 3 millimeters. Do you do a little more in the groin because that's obviously some adipose tissue there?
Sorry, so do you?
Trim at
can
the
you-
skin
You
when
can
you're
crop it back
expanding.
from the skin.
How much he's asking?
Oh,
How much do you trim by?
yeah, I usually do 3 to 5 millimeters if it's very thin patient. If they're more obese, as one of the images showed, you don't actually have to go to the skin surface, so.
Go to the blue football.
Question for Dr. Small. In the treatment of or not advanced, but locally advanced endometrial cancer, when you're treating with pelvic radiation, in what settings, if any, would you recommend an additional vaginal brachytherapy boost?
That's a great question. And this, if you look at the data, we wrote ABS guidelines, was it ABS or ASTRO guidelines in that? I don't think there's a good answer. Certainly most people would give it for cervical involvement with a treatment with non-radical hysterectomy. I tend to give it on, most of my patients that are getting external beam are pretty high risk, so I tend to be a little bit more aggressive than the data supports. But the data really doesn't support much of anything, so I don't think there's a good answer to that, to be honest with you.
There's that one SEER paper
Right.
that showed a benefit in stage 3 patients as well. So stage 2 and 3 can be considered, but we don't typically do it for stage 1 based on the ASTRO consensus guidelines.
Okay, we could probably take one more question.
Last question, the orange football in the back.
Yeah.
For patients with extensive vaginal involvement, do you have a urethral dose constraint?
That's because we just had a patient, we looked at the data. I'll ask Akil to answer, Allison or AJ.
Do you guys want to?
Dr. Wishwanathan?
I do not.
Oh.
I think I use 0.1 to, is it 90? Similar to the bladder dose, but it's a smaller volume.
Yeah, when Courtney's my resident, we were struggling with this, we looked at the data, so we found some of the data talks about 0.1, so we use 90 to 95, but I'm not sure there's great data.
Okay. Well, that was wonderful. I think that we had a wonderful set of speakers who were so fun. And thank you all for turning out.